Question 218. I've got a middle-aged female with a tibia fracture 5 months ago, and she's walking, doing pretty much most activity, no fever chills, and you got a little gap in the front. So what do you do? And this is a really hard question. So you've got 5 choices: exchange nailing, that's surgery; non-union takedown with bone grafting. Those are surgery, and that kind of violates the in-training rule, which is when you have conservative choices, you take them. So those are less appealing. You've got dynamization of the nail. You could ask yourself the question, if she breaks the screw, did she dynamize it? You could avoid surgery with that one. I think the 2 next choices, no change in current therapy or a bone stimulator, are your choices. And I could see a bone stimulator. Now, one of the in-training rules is they don't like to spend money either. So if you can get away with not spending money and not taking them to the OR, that's a pretty good choice. So the correct answer, and the one they were looking for, is no change in current therapy. She's not that bad off. She's doing okay. You could just leave it be. We'll move on to the next question. Question 222. X-rays for a non-healing midfoot wound that didn't respond to a whole bunch of offloading, serial dressings, hyperbaric oxygen, in an insulin-dependent diabetic with severe foot swelling. You have a wound that has a negative probe to bone test, which is not really described, but whatever. Negative probe to bone, which means I can't probe and touch the bone with a probe. Okay, no fever or chills. So the question is what to do. Take a look at the x-ray. Okay, so let's talk about diabetic foot first. First of all, so probably the number one thing when you're looking at a diabetic foot is to establish the air to bone status. So air and diabetic bone are not friends. And that is where the treatment plan entirely splits. So if you have bone exposed to air or the probe to bone test, the things are entirely different. Your MRI is going to show osteomyelitis, so there's no point in ordering it. Your cultures are going to be positive. You're anticipating infected bone. So that's what you have to establish. Now, in this case, it's negative. Now, with that said, I don't necessarily agree with that because that sure does look like air on the AP X-ray. The lateral, you can see maybe has a space, but it looks like it's sort of self-contained. But the AP definitely looks like it's got some air in there. So the real question is, what do you do? Well, transmetatarsal amputation is indicated for a sick patient, so we can take that away. VAC and debridement for someone who's already tried basically everything, not a choice here. Achilles tendon lengthening, total contact casting, an option. Plantar axillostectomy and Achilles tendon lengthening, an option. And then a rigid, ring fixator, so an Alizarov, and taking out the foot. Now that would be, Mickey Pinzer is doing some work in patients with bad diabetes to try to salvage their foot, and that's actually, there's some value to that. But the reality is you got to get rid of the bump. So you got to get rid of the bump, and you got to lengthen the Achilles. So the correct answer is 4. I think that if you picked 3 and didn't get rid of the bump, you'd be disappointed. The answer is 4 on this one. Diabetic foot. Most important thing, and just to refresh, establish the air to bone status. Question 232. 44-year-old self-employed general contractor who has ankle pain and has tried a variety of conservative managements. Limited ankle motion, normal hind foot, and it's tender to palpation. The treatment should include ankle fusion, a total ankle, distraction arthroplasty, interposition arthroplasty, ankle arthroscopy, and debridement. So I think the key thing here is when they include the employment, it's usually pertinent. Now this is a terrible ankle, does not look like a 44-year-old guy. I do not know what he was doing with this. But you've got a bad ankle, and I think you can safely eliminate distraction arthroplasty, interposition arthroplasty. Those are essentially the same thing, and they don't really work in the ankle, so they usually offset. Someone might say, well, he's only 44, I don't want to do a fusion. There is effectively zero chance that this scope debridement would work. That is actually a bad idea. Unhappy patient. So now you basically have ankle arthrodesis and a total ankle, and you've got a 44-year-old contractor. So that is pretty much game, set, match. It should be ankle fusion. Question 235, what's the most appropriate treatment for treatment of this fracture? So you've got a low distal tib fib, no articular involvement. Okay, got your answer? Good. So you look at some of the options here. I think we can probably all agree that you're not going to cast it. That's a big gap. So then you have a question of, do you have reamed nail or unreamed nail? And then with or without fibula plating. So if you look at Tornetta's article, ream nail, maybe it's kicking up all that extra bone material, they do better. So you want a reamed nail, and then the question is, do you want to fix the fibula or not fix it? So if you fix the fibula, you get length, alignment, rotation correct. If you don't fix the fibula, you may have an issue with that. So the correct answer is 2. Get all that good bone marrow and control length, alignment, and rotation with the fibula plating. Question 245, 62-year-old female who had recalcitrant posterior heel pain, 10 degrees of dorsiflexion with the knee extended, failing all non-surgical management. The treatment should now consist of endoscopic debridement of the Haglund deformity, injection of PRP, Achilles tendon debridement with calcaneal exostectomy, Achilles tendon debridement with gastroc recession, Achilles tendon debridement with calc exostectomy, and FHL tendon transfer. Okay, so let's look at the questions here. Endoscopic debridement of the Haglund deformity. They've got calcium and a calcific spur. That has to go. Anytime you have this spur that you can see right there is time to do a tendon takedown and do a double row repair. So question 1 and 2 are not a treatment. Question 3, response 4 and 5 are a viable option, but response 4 is not a viable option because she doesn't have a positive silver skull test. Go ahead and try to spell that. Anyway, she can go and has 10 degrees of dorsiflexion with the knee extended, so that would be a positive silver skull. So that response 4 is incorrect. So now you're basically looking at calc debridement and Achilles tendon debridement, or that with an FHL tendon transfer. FHL tendon transfer is really only reserved for chronic Achilles tendon ruptures, and probably I would stick to that. So the correct answer is response 3, but I do want everyone to take a look and notice the citation. Hey-oh, that's me. Right there, I made the book. Whew, pretty excited about it. Steve Kang, Dave Thortis, and myself wrote that paper and showed that the Haglund deformity is actually not abnormal, with that said, I'm still taking it down when I do this surgery. So a little bit of a miscitation, I guess, of sorts, but and that usually would drive me crazy, but when they cite me, I'm good with that. We've moved here to where they are holding the academy. This is the Venetian, so we'll take a look at the next x-ray. You've got a midshaft to distal tibia fracture. And the question would be, did you see the articular segment? Very, very small. Take a look again. Do you see that articular segment? Okay. All right. So now the question comes down to, what do you do with this fracture? So you've got cast in a short leg cast, a long leg cast. You've got an IM rod with fixation of the articular fragment. And then you've got immediate open reduction through a posterolateral approach and then an anteromedial approach. And the question really comes down to is, can you rod in the presence of an articular fragment such as this? The answer is yes, you can. Correct answer is open reduction internal fixation with fixing the small percutaneous fracture. So throw a rod in there, put a little screw, and you're done. Question 251. Weight-bearing x-rays of a man who has a progressive flat foot deformity, unable to perform a single heel rise inversion, but generates normal inversion strength against resistance without pain. His hind foot is flexible. Surgical treatment should include a triple arthrodesis and Achilles tendon lengthening, midfoot arthrodesis and Achilles tendon lengthening, FDL tendon transfer, post-tib tendon, Achilles tendon lengthening, medial displacement, calcaneal osteotomy, FDL tendon transfer and Achilles tendon lengthening, lateral column, medial displacement, calc slide, spring ligament, FDL tendon transfer and Achilles tendon lengthening. So, hey, there's an Achilles tendon lengthening in all these. I think we can successfully say this patient will be getting an Achilles tendon lengthening. But take a look at the x-rays. This is a great question. So I like this question a lot because it's a reasonable question because you need to know post-tib tendon transfers, and then they throw you a curveball. And they're leading you down the post-tib tendon transfer route, and if you saw post-tib tendon transfer lecture, you think you got this one handled. So you're looking at it, hind foot is flexible. So you're like, okay, well, answer one, triple arthrodesis, probably not the choice. An FDL tendon transfer is a reasonable choice, and you've got FDL tendon transfer, post-tib tendon, and a lateral column lengthening, calc slide, spring ligament, FDL tendon transfer. They're sort of the same thing, and 4 is sort of the same thing. So it's kind of like, well, it's dealer's choice. You know, all these 3 reasonable choices. I know I got this one. I know I got this one. But then you're going to struggle with which post-tib tendon reconstruction to do. But in reality, the single heel rise inversion is due from the flat foot deformity that you see at the level of the first TMT joint. So this is not a post-tib tendon. His post-tib tendon over here, the tailnavicular uncoverage percentage is reasonably good. This is a midfoot collapse. And the correct answer for this one is, in fact, 2. Achilles tendon lengthening and a midfoot arthrodesis, a TMT arthrodesis. Now, with that said, not entirely a fair question. I think if you went in trying to do a midfoot arthrodesis on this alone, you probably would be unhappy. I think I probably would do a gastroc recession, and I probably would do a calc slide on this one. But that's not here or there. That's the correct answer is 2. But none of the post-tib tendon FDL tendon transfers are the correct answer. The posted tendon is working on this patient. Question 260. Question 260, MR images and a scope from a 14-year-old soccer player with anteromedial ankle pain from a twisting injury. They got placed in a cast and she was non-weight bearing. Her ankle ligaments are stable. So the next best treatment is, now one of the reasons I want to show you this is to take a look at an MRI. So here you have an MRI, and they probably say, well, let's get an MRI. And this may look, one image may be difficult for you to interpret. So I do want you to do what I call is setting the compass. So you got one cut, and you need to figure out where you are. So I think everyone can assume in the middle is the talus, but you can't really figure out, is 9 o'clock the fibula or is 9 o'clock the medial mal? And you can assume when you're setting this compass, try to find things that you know are true. So I think everyone, even a PGY1 level, can assume that at 6 o'clock, that's the Achilles tendon. So by process of elimination, 12 o'clock is anterior, 6 o'clock is posterior. And then we're looking at which one is Tom, Dick, and Harry and which one are the perineals. And I think most people would realize that 9 o'clock is the perineals. So that's lateral. Fibula is lateral, perineal tendons are lateral. So we're looking at a lesion on the posterior medial dome of the talus. So that's what you're looking at here, and here are your choices. Okay. So you got a posterior medial dome talus lesion. Here's the scope. What do you do? Okay, now a couple key things. They made this patient really young, 14. Okay, so you've got all these osteochondral mosaicplasty, an OITE procedure, microfracture, and then what's probably Macy. And all of those are fancy, and the in training doesn't like fancy. But in this case, we're looking at a situation where you've got a contained cartilage cap in a very young patient. So what you're going to do is retrograde drilling. So you're going to go from the sinus tarsi, you're going to put a drill under fluoro, and then you're going to confirm where it is, and you're going to then take a reamer, probably like a 5.0 or 6.0 reamer, and come just underneath the surface. Now the technical tip is you don't want to penetrate the cartilage because that defeats the purpose, and then you are going to be going to an OITE or a mosaicplasty or a microfracture. But retrograde drilling, you basically come up underneath the orange line, you scrape around the black hole, and then you fill it with some sort of composite bone graft. And that actually does pretty well. Those patients actually do pretty well. The correct answer is one, retrograde drilling. John Kennedy talked about that in 2009. Question 268, weight-bearing x-rays of a 28-year-old female who has an 8-month history of intermittent pain along the lateral midfoot and perineal tendons. It occurs with running. So which orthoses is most appropriate? A carbon shank with a Morton's extension, UCBL orthosis, a full-length steel shank, full-length semi-rigid insert with arch support and a medial post, full-length insert with metatarsal head recess and a lateral heel wedge. Okay, so this is actually a good thing to talk about, the cavus foot. Now you should know that this is a cavus foot by the subtalar joint. So in a cavus foot, if you can see the subtalar joint and you can look right down it, you know that it is definitely a cavus foot and a varus heel. And that's pretty much, they call it the drive-through sign, but everyone has a drive-through sign, so that's sort of overused. Anyway, the key here with the foot biomechanics is looking at the tripod. So for this foot, we're going to be looking at the balanced tripod. We've got heel in the back, we've got big toe, we've got pinky toe. And for her, the pinky toe is driving too high. So we want to take the tripod and instead of tilting it this way, we want to tilt it this way. Okay, so that's the tripod right there, a balanced tripod. Now for her, Carmen Shank-Morton's extension, that's a big toe hallux rigidus. A UCBL, that's for a flat foot. No one uses them anymore. Steel shank is for midfoot arthritis. And then you've got medial post and a lateral heel. Okay, so medial post is tilting up the medial heel, and it's going to tilt that tripod this way. It's going to make the pressure more. A lateral post is going to tilt it this way, and if you drop the big toe into a hole, that's going to make the foot drive out of varus into a more neutral position. And that's what you're trying to do. Metatarsal head recess with a sole wedge. Question 5, response 5 is the correct answer. Okay, so we're back in studio. Hopefully you took something out of this lecture. Again, there's a lot of gamesmanship in the in-training exam, and you certainly have to, unfortunately, play that. The boards are a lot less gamesmanship. They're more, what do you know? From a standpoint of what I would tell residents to do, I certainly would say for PGY1 and PGY2 students and residents to learn anatomy. A lot of these questions could be answered with the knowledge of anatomy, and certainly the absence of that knowledge, you can answer a lot of the questions. So that is unquestionably the first place to start. If you have any questions, please don't hesitate to contact me at timothycharlton.com. Go ahead and share this with your friends who are studying for the in-training exam. If you go to timothycharlton.com, there's a PowerPoint for 2013, not as fancy as this, but might even be easier to watch on your phone. Anyway, thanks for paying attention. If you have any comments, don't hesitate to call me, and good luck on 2015 and beyond.